Hello, everyone. Good evening, and welcome to this very interesting interactive webinar conducted by the Docplexus in association with the CIMS JIC. I am Dr. Tejas V. Patel, interventional cardiologist, and along with me, Dr. Keu Parikh is there to present today's lectures. I'll just briefly introduce Dr. Keyur. He's a conference chairman and chairman of our institution, CIMS Hospital, Ahmedabad, Gujarat. Uh, he is one of the senior most interventional cardiologists of India and associated with pioneering invasive interventional cardiology work in India. Graduated from the US having triple diploma, a diplomate of internal medicine, cardiology and interventional cardiology, had roaring practice in the US from 1982 to 1995 and moved to Ahmedabad, Gujarat and started his own institution there. He is awarded with multiple awards, especially the William Harvey by American College of Cardiology in 1991. The award was the Distinguished International Service Award by the American College of Cardiology in 2004. Awarded by American Association of the Cardiologists of Indian origin, special award to Dr. Keyur Parikh for the contribution for the cardiology in March 2015. He has been faculty of many national as well as international conferences and has been awarded by multiple national as well as international bodies. So today he is going to present interesting topics which we are going to start in a brief. I am Dr. Tejasvi Patel, interventional cardiologist working in CIMS Hospital, Ahmedabad, and I did my DM cardiology from CMC Vellore, one of the most prestigious institutions in India. I have been trained in Seoul, Korea, Hong Kong for the functional as well as the imaging aspect of the coronaries like OCT, FFR, etc. Have been in US, in UPMC Pittsburgh for the advanced heart failure management and heart transplantation training. Today I am going to be co-chaired with Dr. Keyur for this presentation. So we are going to start the presentation and it will be live soon on your screen.
Is just a brief history of angioplasty. And why I'm presenting it is we are entering the 40th, we are finishing the 40th year of angioplasty since the first paper was presented in 1979 when I was in my third MBBS. When we were in college and medical college, we had no clue, by the way, I had no clue that some people were using catheters even to go into the heart. We had very stalwart textbooks here. And in past, the only reason catheter was put was to visualize arteries in relation to doing coronary bypass surgery. Charles' daughter, and I've been fortunate to meet many of these people. Charles' daughter's idea was to treat an artery without a scalpel. And then Andreas Gunzig's dream was to treat vascular disease with a catheter in a conscious alert patient. And it was between daughter and Gunzig, the entire area of intervention, cardiology, cardiovascular, even interventional radiology has come. This is Andreas Gunzig, and this is his table where he used to make these catheters through some people's help. In July 79, exactly 40 years and 5 months ago, this article came, Non-Operative Dilatation of Coronary Artery Stenosis. It was a landmark article. I had no clue about this article. I was in my final MBBS in Ahmedabad, VS Hospital. And the history actually went preceding by Dr. Sohn. Sohn started the first brachial artery. So if you see and talk about radial access, much before that, brachial access was started by Sohn in 1958. There are two landmark events that happened. Sohn started doing angiography in 1958 in Cleveland, and I was born in Dar es Salaam, Tanzania in 1958. So that was the other landmark event. And then Judkins did the femoral access in 70s and started using it routinely in 80s. Grunzig, who was in Switzerland, started doing first course in, it was in August 78, 28 cardiologists. 1/3 the people who are here right now attended this method, and most of them were just laughing and enjoying. Second course in 79 was attended by 90 participants. Third course in 1980, 170 participants. These are global courses. Hardly people used to come. 81, the first course in Atlanta, he was taken away by Emory University in Atlanta. They invested and brought him there, was held. 85, 86 was his fifth course. This is me with a mustache attending. Total attendees were about 200. This year, Milan Bhai presented a case in TCT 2019 US most foremost course, 10,000 attendees plus. So you can imagine, these were the pioneering years. Same year, another gentleman, Jeffrey Hartzler, started doing acute MI angioplasty. He did recorded case conference. Again, I attended in 1986, kind of looking at it. And the origin started in Charles' daughter, 1969, followed by Hans Wollsten, who had this wall stent, expanding stents. Julio Palmas, they started in his garage. So you can imagine this pioneer starting in garage. Who else do you remember started in garage? And absolutely. So pioneer started in garage. I didn't start in garage, but I started in Ahmedabad. So he started showing, and in that these stents, these were biliary stents, and he joined with another doctor, cardiologist, Richard Schartz. I was again fortunate to meet with them, spend quite a few time here and there with them, much younger in my age. Probably they don't even remember me. And this is a guy, Philip Romano. Anybody knows who is he? Anybody guess? Okay. So when they had these stands, they approach investors to invest to form a stent company. Okay. This is 1980s. I already was in USA. I was doing my residency in medicine, and the first patent in 85, I was in my fellowship in cardiology. Already the biliary stents were used in iliac arteries. I started using them, and these two guys wanted to commercialize. So, and then Richard Starrs, while sitting in an airplane, saw that like there are these trucks, and he then approached this guy, Romanos, what is this? Macaroni grill. He used to go and have macaroni there and food there. So he said, look, I want to start this company. Nobody's helping me. These guys are always smarter, the restaurant people. So Romano invested in the company, and the rest is history. The company did very well. And Johnson & Johnson bought it, even in those days, in hundreds of millions of dollars. So always the history records two doctors and a macaroni owner, macaroni shop. So moral of the story is, if you want to get rich, go in some another industry. And then while sitting on an airplane, he saw these trolleys which were linked. And that is how the flexible stands came. These were the original stand and the flexible stand. So again, from there, Wollsten in Toulouse, France, and then in Lausanne, started treating first in men coronary stenting. And in 1905, Ulrich Sigwart partnered with Mediven Company and did the first coronary stent implantation after animal testing on April 86 in a dissection of LAD. And this is the team. He is not remembered as much as Andreas Grunzig, but I think he was also a pioneering person. I have seen him, met him. This is his pioneering slide. Look at how doctors perceive that. In 1990, ESC had a statement criticizing him, 1990, not too far ago, that you should be ashamed of yourself. It is unethical to put metal in human coronaries. I'll guarantee some of you yourself have metals in your coronaries. And then better and better stents came, better and better trials, new devices, atherectomy, rotablatters, cutting balloons came, and then first generation stents came, Cypher, Texas, Johnson & Johnson, Boston Scientific, sirolimus drug, paclitaxel drug. This is in South America, where Dr. Souza, Patrick, Siraya, some of them were there putting the first drug-coated sirolimus stent. Mother Teresa had stent put by Turstein in San Diego, cardiologist. So everybody now knows about stent. Then second generation stents came, third generation, fourth generation, fifth generation. We are already using our fourth generation stents. Absorbable stents came. I had a lot of lectures on that. Eventually, and I truly believe prematurely, they were withdrawn because of some scaffold clots, which I believe was partly technique related. Hopefully they'll come back. I think 2-3 companies are in the pipeline coming with the absorbable stents. And my final take-home slides are, where are we now? Amazing, amazing history. Coronary stents, absorbers, drug-coated balloons, calcified arteries we opened, directional atherectomy, rotablatters, lasers, distal protection, bifurcation, ostial, left main. You'll hear about this. Chronic occlusion, saphenous vein, acute MI. Acute MI in Gujarat. Even for financial reason, not to do primary intervention is unethical. Any good center can do a primary angioplasty in 70,000-80,000 rupees with a basic inexpensive stent. And if you give streptokinase and manage this patient medically with a persistent block with events, it is criminal. This is one area no trial have shown medicine is as good or better. Forget it. Medicine is inferior. No trials. Hybrid intervention, out of hospital cardiac arrest intervention is coming, cardiogenic shock, peripheral interventions, multiple body parts, congenital heart disease intervention, atrial septal, VSD, PDS, valvular intervention, amazing. You'll be seeing a lot of lectures. Other interventions, almost innumerable. Left atrial appendage, alcohol septal ablation, Milan Bidus has done the highest in the country. Valvular leaks, stem cell deliveries, balloon angioplasties in pulmonary arteries, endovascular treatments. So this lecture is actually a tribute to one person. Me and most of my colleagues have looked at Andreas Grunzig in 40th year of angioplasty, 1979, 2020. He died prematurely. He was so brave. He used to fly his own airplane and he died with his family, very premature age. And he is, I believe, mentor to all cardiologists in the world, myself, alive as well as posthumously. So I would like to end this lecture with the ovation to him, a giant who went through everything.
I have no potential conflict. I have no financial relationship with any commercial entity. I do not take any sponsorship money, funds, travel funds, anything.
And I'll start with the first slide, and this is actually the take-home slide. Trials of LDL lowering indicate relative risk reduction is proportional to absolute reduction in LDL. I had a lecture last year where I mentioned that absolute LDL in the lifetime is one of the most important determinant. And see, this is the most dramatic slide which we have been showing for 10 years. Again, Milan Vai showed that slide in monkeys LDL and primitive tribes LDL of Andaman, where now lower LDL is better, and lower than 40 or almost down to 40 is considered as safe and effective. And the intensity of LDL lowering should be based on risk, irrespective of the cause of risk. So let's start. The new EAS guidelines, the secondary prevention, which is my 99% of my patients. My main practice is angiography, angioplasty intervention. So this is secondary prevention. Prevention who has patients who have had significant CAD. So is your main cardiac practice full of patients who have had MI, post-MI, or secondary prevention. You have two goals you have to take home with. The first goal is whatever their baseline LDL, the new LDL should be, the goal should be 50% reduction. So what that means is all our laboratory normals are garbage. They're just garbage. They're useless. If you have pathologists and if they're smart, then we should start having these footnotes that we should have 50% reduction in LDL. And LDL should go below 55, a dramatic jump. If you look at just 5 years ago, it was 100 and then became 70. So in 5 years, we are talking of same 50% reduction of what we consider as normal. And this includes secondary prevention. This also includes primary prevention with very high risk, which means the people who have not had events, but who are diabetics, who have CKD, who have high LDL levels, who have very strong family history, who have peripheral vascular disease, are same. These are both class 1 indication. That means that is your goal now. And class 2A is primary prevention with very high risk with family history. Here there is no family history requirement. Here is family history. So LDL goal of less than 40 is class 2B, which means you can do it. There's not enough evidence. There's no harm also, but it's something what we have seen over the years is 2B ends up 2A, 1A unless something was found to be very dangerous. So lower LDL is better for patients at very high risk of recurrent atherosclerosis, cardiovascular disease. So original EAS guidelines, 70 we remember just last year or year before, we were talking 70, has come down to 55. What was 100 has come down to 70. And what was moderate risk is still less than 100 and low risk under 16. What this means is this is the lecture I should be invited to give in all pathology conferences across India. Unfortunately, they've never invited me. Doesn't matter. So we have to go through the changes. So this graph shows that if you are the lowest risk, 116 LDL. Now in lowest risk, we don't have epidemiological data, but if you look at epidemiological data, Indians are preponderantly highly susceptible to premature CAD. So I think there is no Indian who is low risk. I truly believe. I mean, there may be rare cases of high HDL patients who may be low risk in India, but all Indians by and large as a community have a very high type C LDL, the small density. So we are all moderate risk. And as we go down high and very high risk, the reduction has to be more and more aggressive. Again, 55 is the magic number. So getting patients to LDL-C goal, use of maximum tolerated doses of high intensity statin is now the goal. It is still very unfortunate to see very low dose statin given to these patients with heart disease. Add ezetimibe, and this is the most important molecule that has been emphasized in last 1 year to all these guidelines. It's class 1, level B. Class 1 means it has to be used. Level B means intermediate level of evidence. And consider adding PCSK9. In India, Repatha is available, fairly expensive, distributed by Dr. Reddy, made by Amgen. If ezetimibe and maximum dose of statins are not achieved, does not achieve the ideal goal. The future of lipid lowering is to reduce cardiovascular LDL-C. And as I mentioned earlier, that being an Indian, there's enough data to show that we have very high LDL-C compared to the total LDL. So that brings another confusing thing that our normal LDLs are not reliable. If our LDL-C is very high, then the pathology lab reporting even less than 70 or less than 100 may not be as accurate. So start early. Less LDL exposure leads to prevention. So this is total cumulative LDL in the body in lifetime. So start early, LDL reduction. Treat much more aggressively from the desirable target to LDL-C elimination. This is something which I want you to make understand. LDL-C has no useful role, absolutely no useful role. So you have to eliminate LDL-C. And there are pharma molecules being studied to eliminate LDL-C. Amazing. I'm glad I'm 62 now, and my colleagues are still fairly mature, that in 20 years, intervention may start becoming obsolete. And I truly believe. Concept 3 is use combination therapy, statin plus ezetimibe, plus again in Indian scenario, cost is an issue, PCSK9. Why is this coming? All historical trials are showing that as statin therapy reduces LDL, this regression of atherosclerosis. We know that, very old data now, almost 20 years old. And now all the data is showing that ezetimibe, adding ezetimibe reduces LDL-C significantly, which means it is a very important molecule. HDL-C marginal rise, suddenly from 5 years ago, you see we don't talk about HDL, we are still confused what's happened. And it's an area which is very controversial because no molecule is coming which is raising HDL and helping survival. Triglyceride is coming back as a bad molecule again. For a while it was neutral, then it was bad for diabetes, now it is bad for everybody. And the greater benefit from ezetimibe added to statin is more the risk, the higher the benefit. Again, in various endpoints, control group versus ezetimibe already on statins are showing significant survival benefit, cardiac death, MI, angioplasty, bypass, and or stroke. And already you know in stroke too, just yesterday or day before an article came, NEGM, showing significant advantage in stroke reduction using high dose of statins, though they have not come with the goal. But that's all right. Neurologists are about 10 years behind cardiologists. They'll keep on following us. So risk categories, ACC, ESC, in brief, higher risk groups can benefit from additional LDL lowering. Ezetimibe. So role of ezetimibe in 2020 from evidence to molecule of optimal care. So tailoring lipid lowering based on patient and disease characteristic will now become very important. Unlike the pathology laboratory form described controls and normals are useless, totally useless. It should be prudent if they can put these guidelines on the back footnote somewhere. And we may do that in our hospital shortly, that this will be a guidance. So again, low risk, 116, moderate risk 100. If Indians we consider as a population are moderate or higher risk, then almost every Indian should have a LDL less than 100. Now in that, mark elevation of a single even factor, and there are quite a few factors which I mentioned, or family history without other major risk factors. If you ask that, who has family history of heart disease, can you raise your hands? Father, mother, almost 70% of family history of heart disease of some sort. So we are already high risk. So family history without other major risk factor is a high risk. Diabetes without target organ damage is high risk. Diabetes more than 10 years is high risk. Moderate CKD is high risk. These are high score patients. Or with primary prevention also it's 70. And very high risk again are obvious. To start summarizing, moderate intensity statin 30% reduction, high intensity statin 50% reduction, high intensity ezetimibe 65% reduction. Let me ask you, if you consider yourself as moderate to high risk, and if you are looking into this goal, how many of you are personally in primary prevention following this goal? Can you raise your hands? How many of you? Milan bhai. Okay. Amazing. Amazing. Good. So I think we may still be in business for a while. Are we reaching repeat goals in high-risk patients? We don't meet these goals. Why don't we meet these goals? Lack of adherence, absolutely. Drug intolerance, absolutely. Patient characteristics, lack of lifestyle changes, 1000% accurate. Failure to titrate to more potent dose of statin, yes. Underuse of additional therapy and inadequate follow-up. So there are very many legitimate reasons where we don't reach this goal, more so in female, stable angina, obese, sedentary lifestyle, and smokers. They don't, and tobacco users. People with diabetes and CKD are reaching these goals more frequently. So what is my take-home message? Statins remain a mainstay now, absolutely mainstay. If anybody believes it's memory loss, me and again, Milan, we have been taking at least for 20 years, right, Milan bhai? 20, 25. So I don't think I have memory loss. I have selective memory loss, but not general memory loss. Addition of ezetimibe provides further LDL-C lowering. This is a drug we should start increasingly use. New guidelines endorse lower LDL-C goals in only about 1/4 of very high-risk patients. This, as we saw in this hand raising. Again, two things I want you to remember, just two simple things. LDL reduction of more than 50% from baseline with an intention to reduce 55 milligram in deciliter is one goal. And second goal is again LDL reduction more than 50% of baseline and below 70 in the remaining patients. This should become our mantra numbers. Everybody has a voting pad now? Everybody? Make sure. So according to these guidelines, what is the secondary prevention reduction from baseline goals? Start punching. Timer. Are we ready? So about out of 50 people, 5 people. Can I go back to the slide now? At least 50, the correct answer. Now, earlier Milan bhai said that he manages his LDL to reduce below the goal. Patients with atherosclerotic vascular disease with recurrent events on maximally tolerated doses, which is the lowest possible LDL goal that has shown benefits in future events. Timer. Slides. 40. Below 40 is the correct answer. Can I go back? LDL of 40C. And this is my 22 November LDL, 44.3. I exercise 2 to 2.5 hours a day, 100%, 7 out of 7 days, except during conference, only 1 hour today. I do 45 minutes of brisk walking on a treadmill. I use treadmill because it just gives me very control. I don't use incline. I do 30 minutes of stationary bike with increasing resistance. And last 1 year, I'm now doing isotonic muscle building exercises. And in the evening, about half an hour. I do it religiously every day. I think we have a lot of time in the day. Anybody who says he doesn't have enough time needs to understand time management. How many of you attended Ramesh Daggubati's talk on left main bypass versus angioplasty yesterday? It's full of statistical slides. And I always get confused in these statistical slides. So today I'll show you some pictures. Nothing to disclose. Angioplasty for left main disease is increasingly viewed as an alternative to bypass. He talked about it. What he didn't talk is that this is done under imaging. It's mandatory that you have to use either OCT or imaging, IVUS, and OCT is optical coherence tomography. And during PCI, this optical coherence tomography from inside looks at the arteries. Now, some of these trials, including Excel, didn't mandate compulsory OCT or IVUS, didn't mandate that. In some places it was done, but some places it was not done. Some places it was done, but after the stent was placed, the double checking was not done. So whenever a trial is conducted, we are finding an intervention, the technology supersedes by the time the trial ends. So at the end, what I'm going to show you is just few cases where we believe that the outcome was very good. This is a patient, 79-year-old, very fragile lady, one of the doctors from Baroda's mother, who had left main coronary disease, triple vessel, was booked for surgery by Dhiren Bhai, happened to know us also. Patient was advised early CABG. During pre-CABG, she was diagnosed to have significant laryngeal deformity. So it was decided not to do the surgery. This is the patient. This is the left main. Can you see this here? Fairly significant. It was very significant, class 3 to 4 resting angina. So we used OCT again. I won't go into the detail. It's fairly technical. And we did a very complex TAP-T technique and with angle, and then there is a double stent. And this artery looks excellent. This was followed by again OCT, and we did some revision post stent balloon dilatation, precision. Patient has done extremely well. She's in her 7th month. The laryngeal deformity still is there, but she's symptom free. Another patient, ostial left main. This was one of the first indications which became reasonably class 2 for stenting. Again, OCT, look at the images, see the artery, size it very properly. Problems with left main stenting is undersizing of the stent, not doing enough post dilatation, over length, under length, all those issues can be resolved. This patient had an LED stent earlier, which was patent. We did put in an ostial stent, ostial left main, looks great. And then we did the post-stent OCT here in this stent here. Another case, moderate disease, moderate to severe, class 3 to 4 angina. This is where we did not used to do stenting almost 3-4 years ago. This was avoided, the distal left main bifurcation arteries. Again, you look at it with OCT, and then you insert the stent, you do kissing, etc., various technique. Final result. This is almost a year ago, more than a year ago, doing extremely well. And post-stent OCT is an overlap. There are 2 stents here. This is, I think, the last case, highly complex case. The whole left main, if you see, is extremely diseased. And patient was very fragile. There's a frailty index, and the surgeons decided not to do surgery. Patient was having class 4 angina, to hardly walk a couple of steps. Very fragile gentleman. We went ahead with OCT, diffusely diseased, went through a complex stenting, and eventually this is the result here, as you see. And then you see multiple overlapping stents, a position. These are stent struts. All these are very precise things. That's why some of the papers in left main stenting has not shown benefit, because I still believe that proper placement was not done, proper post-stent precision imaging was not done, which is mandatory. So to sort of conclude, what he said in Excel trial was that initially angioplasty did better with less events, and then the crossover. But that will happen in most of the trials, like even aortic stenosis, TAVI trials. At the 10-year, people die. So initially there's an advantage, and then at 10 years. So let's have a trial of 40 years in a 60-year-old patient. At 40 years, at 60 years, you're 100 years, you're all going to die. So again, this becomes very interesting to see how old the patients were. And when at the end, you start mixing, then taking plain water against anything,
At 20 years, there's no difference, because 20 years, you take plain water, you take statins, you all die. If you start the trial at age of 60 or 70, you all agree. So people don't analyze that. So conclusion, in carefully selected patients with left main coronary artery disease, using post-procedure, pre and post-procedure, either OCT or IVUS, and we have both technology at CIMS hospital to evaluate proper stent expansion, stent apposition, outcomes are very good and it can be managed. So I'll end my talk almost half the time. Thank you very much, everybody.
Good evening, Dr. Tejas.
Hello, good evening, Dr. Kayur. So it was a nice, lucid lectures talk regarding the three different topics, and you have enlightened all of us very well about the lipid management, about the past and the future of the angioplasty, as well as one of the very interesting topic, left main intervention. So let's see the questions. So let's start with the question answer session. So we have a couple of questions, very interesting questions asked by the audience. Congratulations, all of you, for participating in the interactive session, first of all. And let's start with the question number one. So, is cholesterol harmful? Is butter oil is harmful? There is a one question, Dr. K. Would you like to give the answer, or is cholesterol harmful? Is butter oil is harmful?
Yes. Universally, I'll tell you one thing. Cholesterol, LDL, is indeed harmful. And in Indian population, we believe the little LPA, as we call it, lipoprotein little a, LDL, is definitely harmful. Butter is definitely harmful. There is no data which shows butter is healthy. Ghee, there is a data, sporadic data, that ghee may be used, not as harmful. How helpful it is, we don't know. People have said that 1 or 2 teaspoonful of ghee a day may be useful. So there's no randomized, there's no big trial. But one thing I can tell you, that cholesterol, by and large, LDL is harmful, and almost all recent data shows the quantum of LDL, total LDL in the lifespan of a person, is determinant of his cardiac mortality.
Right. Excellent. Another question is there, how to face stress and how many working hours for keeping good health? So it is completely subjective, I would say. Yeah. Yeah, Dr. K.
Yeah, I'm 62.
I think.
So I do exercise 1 to 2 hours a day. As I'm getting older, I exercise more. How many hours is useful working hours? Anecdotally, 40 hours a week is good. But if you're a doctor, you are genetically inclined to work 60 hours a week. There's no studies, but to be active is very important, and you should enjoy what you do. So
I think the working right. I think working atmosphere is also very, very important. Actually, in our place, we are working even day and night. Still, there is not much stress because of the lots of other reasons. Like one of the reason is good group practice, but definitely the working atmosphere. Where do you work? That again is a very important parameters to combine come with the stress. There is one good question. Yes, I am 55 years at present and had undergone angioplasty with stent for mild angina with 90% block in LAD 3 years back. I am normotensive with subnormal lipid profile values. Do I still need to take 40 milligram of atorvastatin with metoprolol and ramipril in addition to the aspirin? So I think I'll give the answer. Definitely you have to take the 40 milligram of atorvastatin. I would say if you can tolerate 80 milligram atorvastatin is the as per the guideline, or 40 milligram of the rosuvastatin, that is called as high intensity statin therapy in all the patients diagnosed with the coronary artery disease, post CABG, post angioplasty, post ACS, or the patients with the diabetic and the peripheral arterial disease. One caveat is there specifically in the Indian population, if they cannot tolerate, if there is a side effect like the muscle intolerance, which is very, very subjective, and other side effects of the statin, then in that case you can reduce the dose. Or else if your LDL is very much low, which is very, very rare in patients, you can reduce the dose. Otherwise, you should take 40 milligram, and I would say 80 milligram of the atorvastatin per day should be taken if you have undergone angioplasty in the past.
I would I would also add ezetimibe. You are
Right.
secondary prevention, and if you go to the even primary prevention, you are high risk. So ezetimibe should be almost mandatory in case like yours. But more than that, when you say subnormal lipid profile values, you have to ask yourself, what is subnormal? Most of the recent data suggests that survival benefit continues till LDL below 30 or LDL below 40. 4-year study using PCSK9 inhibitors showed that. So the normalized numbers which we have been told, and if you listen to my lecture and the slide which I showed, is not true normals. If you want to really go to normals, you have to go to apes, monkeys, a childhood normal, which is a baby or an 8-year-old boy, where the LDLs are more like 50s. And that is what I believe should be the normal. So first, never believe you have a subnormal lipid profile. I, as a primary prevention, moderate risk because of family history and a CT angio showing a plaque of 30% many years ago, take 40 of atorvastatin with 10 milligram of ezetimibe, and my average LDL, which I check twice a year, is 40. Am I satisfied? Right now I'm satisfied. I may not be satisfied in future, and I may bring it lower. So the next question is very similar, and third question. One is role of statin in plaque reduction in coronary disease. Absolutely, there are a lot of studies. So I had a CT angio done 15 years ago for some cardiac chest pain. I had a 30% plaque. I started taking statins since then. I did one follow-up CT scan, which I would not recommend routinely, and my plaque at a 15-year follow-up is about still 30%. A lot of studies have shown there is plaque regression 1 to 2% per year. Significance of LDL in Asian dark skin population, extremely high, especially Asians. When you say dark skin, Africans are also dark skin, but in South Asians, that ACC in USA has categorized South Asians from India and Pakistan as a separate risk marker. Go ahead, Tejas, for the next questions.
Yeah, I think one out of the blue question, aortitis, bacterial, and incidences in community as a whole. So frankly speaking, I don't have any idea about that thing, aortitis bacterial, rather than aortoarthritis or the inflammatory aortitis, which is common in the Eastern countries as well as in India, which is we call as a Takayasu arthritis. Bacterial infection is always secondary to some source of the some foci of the infection in the body, and more commonly it is a part of infective endocarditis, but it is still very, very rare complication of the aorta. It is common, mycotic aneurysm is common in the brain. So I would say in the community as a whole, aortitis bacterial specifically is very, very less likely or less common rather than inflammatory aortitis, which is more common. The next question is,
yeah, go ahead.
Yeah, so for triglyceride other than drugs, for so far not being invented, I advise omega-3 fatty acids plenty in fish oil capsules as well as in walnuts. these are expensive. Instead, what would you digest for those patients with more than 250 milligram, since our staple diet is more than 70% carbohydrates? So it is something expensive.
I think the question is again,
It is confusing
omega-3
question, but
fatty acid, fish capsules. What we have not been able to ascertain after decades of research is how useful they are. I have off and on been taking those. There's no real data to prove that they are useful, but there are no data to show they are harmful. So let us presume that I would not recommend uh, as a therapy for either primary or secondary prevention, because as the questioner asked and commented that it is expensive. I agree. So I don't take any of these last many years.
okay. The next question, let's go to the triple vessel block. One is 100%. Is it compulsory to go for bypass? Number one. Number two, if yes, what is the criteria to success rate, and is PET scan is necessary to be gone before going for the bypass surgery?
Should I
So I
answer?
think
Okay.
Dr. KU.
Yeah.
Yeah.
First, triple vessel in a non-diabetic, you can undergo intervention with angioplasty. You don't need bypass, but if you need bypass, you can. 100% does not mean you need bypass. 100% just means the artery is blocked. But the more the vessels are blocked, and if you have diabetes, the outcome of revascularization, which is bypass or in some cases angioplasty, is always superior, and more so bypass is superior in triple vessel diabetics or with left main. All the studies have shown. If you have unstable angina, yes, bypass or revascularization is superior. If you have heart failure, if you have LV dysfunction, revascularization is superior. Now, is PET scan necessary to done before bypass? Not at all. PET scan is a fairly expensive test. You don't need it. If you have either abnormal treadmill, unstable angina, heart failure, LV dysfunction, diabetic triple vessel disease, this is good enough indication to undergo revascularization, preferably bypass. If you are asymptomatic, who as an incidental finding ended up with an angiography or with very minimal symptoms, very stable, and one of the arteries 100% block, and if it is not LAD, it is circumflex or RCA, and the other two arteries are moderately diseased but less than 75% diseased, then you can definitely be managed medically. Again, if you are not diabetic, if you have good ventricle, if you are minimally symptomatic, if your treadmill is not abnormal or or mildly abnormal, and if you're still in doubt, then you can get a stress thallium, which I would presume is what you meant instead of a PET. Role of telemedicine in cardiology, Dr. Tejas.
I think you are the best person. You have done a lots of. You are doing it routinely, almost daily, 15 to 20 patients.
Yes, during the
So
lockdown,
I
we
share
really increased
your
our.
experience. I think that would be better.
Yeah, I'll tell you two things. There is some role of telemedicine, but I don't think it will replace regular medicine. Telemedicine, mainly in terms of consultation, is a good approach. However, in cardiology, there's a limitation. You cannot do many tests such as echocardiography or a good auscultatory exam. Either of them, if you don't do auscultatory exam, then you need a good echocardiogram test. You cannot do that on telemedicine. But a formal initial teleconsultation is fine. My take of telemedicine is that future of telemedicine is not that terrific. It is height. It has a limited role. I think that doctor medicine in physical presence of a doctor and patient will not go away. Yes, we may be sitting 3 or 4 feet apart and have proper social distancing as well as PPE with masks, but seeing a patient family in physical presence will not go away. Telemedicine, however, will have its own limited role.
Right.
Dr. Tejas, go ahead. I think you
Yeah.
can go to this
So the
question.
next question.
Yeah, go ahead. How long
So next
rosuvastatin?
question:
Same.
how long rosuvastatin should be continuing?
To keep the target LDL low. Target LDL is based on the
Yeah, I think I'll
primary.
give the answer.
Yeah, go ahead.
Yeah. Yeah. So once you are taking it for the secondary prevention, that means you have either heart attack in the past, any ACS in the past, angioplasty, bypass surgery, any revascularization, you have the diabetes, or you have the peripheral vascular disease, stroke. It should be taken lifelong, as we mentioned before in the moderate to high intensity statin dose. For the primary prevention, again, the target is one of the criteria which you can chase. But many a time, most of the time, if it is a familiar thing, you should continue it for the lifelong. LDL target less than 50, lower is better. That should be the primary achievement when you are taking the statin, any form of the statin.
Next question
Okay, so
is,
next question: what are the post interventional follow up care or routine screening that should be done to avoid complications?
you can answer that, Dr. Tejas.
Yeah, so post-intervention follow-up usually requires aggressive. First thing is proper counseling of the patient regarding the medications and lifestyle modifications, specifically for the secondary prevention. That is very, very important. If the patient having heart failure, we need to plan for the cardiac rehabilitation also to improve its physical capacity. Other important things are routine checkups in the form of echocardiography and the treadmill test whenever it is appropriate. And the third most important thing is to modify the risk factors. These are the diabetes, hypertension, lipid. So we need to check regularly HbA1c or the diabetes status as well as the complete lipid profile, and we need to adjust the medications accordingly. So these are the very, very important routine measures or routine screening which we need to do it in all post-interventional follow-up patients. Anything you want to add, Dr. Kev?
No, I think that is good enough. We can move to next question, which you will be the right person
Yeah,
again. Role of CT and MRI in diagnosis of left main disease.
yeah. So it
CT
is very,
in
very
terms of
good
imaging
question.
and MRI in terms of perfusion MRI scans, which we do, rather than
Right.
imaging.
So
You can flip the question and answer it from both anatomical and physiological perspective.
true, because we are doing both the things in our institution. So CT is really excellent tool for the diagnosis of the CAD per se. Definitely for the left main disease also it is very, very good. The only limitation of CT is the small caliber of the vessel, specifically if less than 2.5 millimeter. And in the diagnosis of the left main disease, left main is roomy and the large size. So definitely CT is one of the good investigation to look for the left main disease. Now, another important tool of the CT is to look for the left main intervention, post left main angioplasty to look for the stent. Again, CT is very, very important. Usually, we restrict the use of the CT scan for the intermediate risk patients who are mildly symptomatic, asymptomatic, or with a strong family history. If you are suspecting left main disease or the strong symptoms, straightforward you should go for the coronary angiography, which is more better and more giving clues for the further intervention. Regarding the MRI, I would say MRI is much more useful for the perfusion and the viability of the myocardium, which can be used post infarction as well as post angiography to know the gadolinium enhancement in the area during the stress as well as at the rest to look for the scarring, to look for the perfusion, and that is one of the gold standard as per the current SEC guideline in comparison to the PET scan. So both have the different modalities and both having specific use in terms of the cardiac imaging.
The next question is, what are the characteristics of patient to be an ideal candidate? So in other words, what are the indications for coronary angiography? Indications of coronary angiography.
Yeah, so I would say, yeah, there are lots of indications of the coronary angiography. I would say any patients with the acute coronary syndrome, unstable angina, drop positive, ECG changes with echo showing LV, regional wall motion abnormality should underwent for the coronary angiography as soon as possible, preferably within 24 hours of the onset of the symptoms. If the patient having ST elevation myocardial infarction, it should be considered as a primary angioplasty as a part of the coronary angiography. Now the asymptomatic, mildly symptomatic or non-SCS patients, let's say the patient having coronary angina, effort angina, those patients are the candidates for the coronary angiography to know the coronary anatomy, to know the lesions characteristics and the site of the lesion which is creating the problem. And in that case, even CT coronary angiography in appropriate patients can be done to look for the to know the coronary anatomy. And the last subset of the patients who are asymptomatic. So there are patients with who are asymptomatic but having strong family history, strong risk factors. The patients with the very strong stress test like the TMT or stress thallium scan or even dobutamine stress echo. Those patients should undergo coronary angiography to know the coronary anatomy and the lesion characteristics. That again can be done with the routine angiography as well as CT coronary angiography. Both are equally good, and the recent trial has shown both are equally good for the decision making in the further treatment in such type of patients.
Next question. During interventional surgery or intervention, what are conditions that can pose a risk during the procedure? Now I can answer that. If patient is in shock, patient is having very low blood pressure, cardiac arrhythmias, these are high risk during intervention. But many of these patients do benefit also during intervention when they are in that shock or cardiac arrhythmias. I can pretty much tell you that in intervention, basically 99% patients do very well. Don't you agree, Dr. Tejas? It's present day and era. However risky the intervention is, the support in the cath lab is so good that the intervention
Right.
itself has much more benefit than the risk of intervention. So I would not consider any condition which will pose a risk during the procedure when the indication of the procedure is correct. If the indication is incorrect, like if patient does not need a procedure and you're doing a procedure, then itself is a risk. So I would tell you that nowadays procedural risk is very low in most of the interventions done safely. Next question is, and we'll have probably last couple of questions. A child of cardio-diabetic parents, at what age you will start statting along with exercise? Very interesting question. So a child of both parents having cardiovascular disease, presumably, and diabetes, or a combination. So what should be done in terms of statin and exercise for primary prevention? What age and what should be done? Go ahead, Dr. Tejas.
Yeah, so I think the role of statin again, it depends on the in the children specifically, it depends on the LDL level or any inherited dyslipidemia. Regarding the exercise, it is very important and prudent to start the healthy lifestyle and lifestyle modification from the childhood itself, when you have a strong history of the heart problems and the diabetes in the parents. So definitely the exercise is very, very important along with the diet modification and the healthy diet consumption. But the statin, I would say, when you have to be vigilant regarding the lipid profile and regarding the other inherited form of the dyslipidemia, and in appropriate case, you need to start the statin. Specifically, as per the various guidelines, every child of the cardiodiabetic patient should undergo the lipid profile checkup, and in all the patients, all the person at the age of 20 years should do at least lipid profile to know their lipid status and to do the appropriate lifestyle modification.
Last question, Dr. Tejas. As per cardiogram, how do we differentiate left main CA with accelerated hypertensive changes?
Yeah, so it's a very good question.
But yeah, go ahead.
So it's a very good question, and many times we have many clues in the ECG, but at the same time those clues are misleading also. So I would tell 2 or 3 important clues which can differentiate between these two situations. Now we have encountered that the patient with the hypertension, severe hypertension, long-standing hypertension, accelerated hypertensive changes, many times having ECG showing LVH with strain pattern, and those patterns usually mimics the ACS, acute coronary syndrome. So one important clue to differentiate between these two is that when there is a hypertensive changes in the ECG, the T inversion, which we call as a secondary T inversion in the patient of the LVH with strain, usually happens in the V4 to V6, specifically in the V5 and V6 leads, in the chest leads. While the patient having significant left main or many times proximal LAD lesion, what we call as a valence kind of pattern, which usually happens in the V1 to V4. So that is a very, very important differentiating feature. V1 to V4 T inversion is suggestive of critical LAD or left main lesion. V5 or V6 T inversion along with the LVH as per the voltage criteria, that is suggestive of hypertensive ECG changes. Another important clue is that important clue of the LMCA disease is that AVR, you will see the ST elevation and more than 5 leads, limb leads or the chest leads, more than 5 leads showing significant ST depression. That will be from V1 to V6, specifically from the V4 to V6 along with the inferior leads, and at the same time you see the AVR showing ST elevation. That is again suggestive of something which is you are dealing with the left main disease. So these are the 2 important clues which you can see when you have such kind of a situation and when you encounter such situation.
I think this was
So I think we have done all the questions so far.
Great discussion. And I would like to thank Docplexus to bring this terrific session and be the leader in the country in academics and medicine. Thank you very much for everybody. Thanks to the audience. Thanks to Kritika and her team. Thanks to Docplexus. And thank you, Dr. Tejas Patel. Thank you very much.
Thank you.
Good night.
Bye. See you. Good night. Have a nice day.